So just wanted to say hello and thank you for everybody who can make it tonight. Of course, stop, ask questions, please. But we are very excited to have Dr. Edmondson here to talk about equine proximal suspensory treatments, and she is an associate at BW Furlong and Associates. And I'll let her introduce herself from there, but Dr. Furlong runs a great business out of Oldwick, New Jersey, and took care of my horses when I was a child. So she's working with the best of the best, and I'm excited to hear what she has to say.
All right. Well, I will take it away. So my name is Julie Edmondson, just to give a bit of background. I am from the lovely Ireland. I have been in the States for nearly 2 years now. I completed a rotating internship at BW Furlong, and then I stayed on and I'm doing kind of a sports medicine fellowship and working very closely with Dr. Furlong himself. So, as you can imagine, we have a very high caseload of sports medicine cases. So, we get to really see a lot of weird and wonderful things and the very, very common things as well. So, this is just kind of a quick, short, presentation of one of the cases that I saw in the practice. So it was a case of a warmblood gelding. He presented for this persistent right hind limb lameness. Around 11, sort of a low-level show jumper job. And has kind of had this like intermittent duration of about a year of this lameness. So initially on our exam, he was definitely demonstrating a moderate right hind lameness, about a 3 out of 5, which was consistent all around on hard ground, soft surfaces, and most definitely positive to flexion test. On palpation as well, there was no obvious swelling, but definitely a moderate sensitivity over the proximal medial metatarsal region. So we kind of started from the bottom with this lameness, as Dr. Furlong would kind of tell us to do. We would start kind of from the foot up, just in terms of like blocking to kind of differentiate where this source of lameness is coming from. And it wasn't until we sort of got higher up the leg to perform a deep branch of the lateral plantar nerve block. And this quite significantly resolved the lameness. So then, kind of after the blocking, we did some ultrasound images of the proximal suspensory, and there was quite a notable hypoechoic area in the lateral lobe of the ligament. And most of the time when you're ultrasounding these proximal suspensories, especially in like a middle-aged warm blood, there are always changes. They're somewhat enlarged. You know, these horses have been working quite hard throughout their lives and competing at intense levels. But in this particular case, it was quite apparent that this right proximal suspensory was quite enlarged in comparison to the left. So these are kind of some of the images. We kind of typically say that there's enlargement if the cross-sectional area of that proximal suspensory ligament is greater than 1.5 to 2 centimeters in diameter. So you can just kind of see from the comparison to the left and right, it was definitely enlarged. And then we just did take some x-rays, because sometimes on x-ray you can see changes from these proximal suspensory desmitises, especially where they originate at the back of the cannon bone. But interestingly enough, this horse in particular on the lateral splint, as you can see here, there were some changes on that splint, which kind of goes hand in hand with that ultrasound that we saw, that there was more notable changes on the lateral lobe of that proximal suspensory. So in layman's terms, kind of just like the outside of the leg. So then in terms of treatment for proximal suspensory desmitis, it's kind of a whole rounded approach, and it takes some time and effort when you truly do have this diagnosis. So the horse definitely needs some time off, and but with that needs some controlled exercise. Like, we never say to completely stop exercise and movement. The most significant part of our treatment plan most of the time for these injuries is Shockwave, and it's really important as part of their treatment plan. So typically the protocol that we would prescribe is that we would give 1 session every 2 weeks for a total of 3. In this particular case, we also did treat the hock joints in this horse, just because there were some changes in the hock as well. And then just some additional supportive therapies. So we try and support the biomechanics to kind of take the load off that proximal suspensory. The function of the suspensory is to prevent overextension of the fetlock joint. So we're trying to kind of stop overloading that suspensory by changing the shoeing, kind of raising the heels. We also do a short course of some anti-inflammatories just to help that inflammation. And yeah, so this is kind of just a quick overview of what the Piezowave therapy does. So the device itself, it uses crystals to create the shockwave through an electrical stimulation. I'm sure the guys could probably get a lot more into the nitty-gritty of that. While the traditional electrohydraulic devices, they produce these kind of shockwaves by creating a spark in a water medium, and results in kind of this larger focal zone and potentially like this less precise energy delivery. So what the Piezowave therapy does is it increases cellular metabolism, neovascularization. So basically bringing lots of blood flow into the area, trying to reduce this chronic inflammation that's been going on in the area. And the biggest factor with the treatment is the analgesic effect, so that pain relief. It's a really tight area, and when that ligament, like the proximal origin of it, expands and becomes inflamed, it compresses this pretty important nerve, the lateral branch of the plantar metatarsal nerve, and that kind of causes like this low grade neuritis and pain for the horse. So that definitely helps in pain management for the horse and aids in bony remodeling of the cannon bone. So why do we kind of decide to use piezo over our regular shockwave? It's just because it's more focused. It's a more precise treatment, and it's way more tolerated by the horses than the traditional shockwaves. So just to kind of go more into depth of why we use Piezowave, I was pretty astounded when I first used it, because I've used a lot of the traditional electrohydraulic shockwaves, and they're really loud, and it's kind of unnerving when you have to sedate a horse so heavily to shockwave its hind limb suspensories and you're down behind the horse. And you're kind of anxiously turning it on, trying to make sure they're not going to freak out, and then have to apply it to the leg. It just makes for a way easier and calmer experience for the horse. And you very rarely have to use sedation for it or excessive restraint to apply this therapy. It's a lot more gentle than the electrohydraulic. And there's kind of different standoff gel pads which just allow you to kind of tailor the treatment to the area that you're going to treat. I just think it's so much more user friendly, the way we're able to control the pulse intensity and the frequency. When I first use it on a horse, I'll kind of have it down on the lower settings and increase it as they tolerate it. And there's just better compliance with us being able to use, little sedation. The horse is more relaxed. It's safer for us. We don't have to wear ear protection, which a lot of vets should be doing when they're using the traditional shockwave treatments. And it just kind of leads to a much nicer experience for everyone involved. So in the practice, we have the FB10G6, if I'm pronouncing that correctly. Sorry, Cindy, did you say something?
I said, you're correct. You got it.
Okay. Yeah.
FT36.
So this is the system that we have, are very lucky to have in the clinic. And it's definitely grown in popularity with our vets. So the typical protocol that we use, or I used in this case, was use like a 30 or 40 standoff pad, and use 3,000 pulses on the proximal suspensory. And typically I would start with the intensity around 4 and kind of go up as the horse tolerated it more. And if the horse tolerated a certain level, I would just kind of maybe start there the next time for the next treatment. So this is kind of the energy flux density measurement, I suppose, of the levels that we use. And over here on the left is what the machine looks like when you're using it. So it's quite easy once you get the hang of it, of how to use it. The left side is the frequency, in the middle is the number of pulses, and then the right is the intensity. So the follow-up of this case, I kind of followed up with it quite a bit because I'm always interested to see what happens with these cases and how they progress with their lameness. And this horse responded very well to the shockwave and kind of the reduced exercise. The lameness was significantly improved at 12 weeks, so the horse was introduced back to work and has maintained and improved in soundness. These are the follow-up ultrasounds, 8 weeks. The cross-sectional diameter is reduced, but the suspensory ligament will never truly probably look the same. They're difficult ultrasound images not only to get but to interpret as well, unless you're the person who's kind of obtaining the images. And really, like, the true kind of gold standard for imaging the PSLs is MRI. So just some PSL studies kind of on their return to work, and the difference between hind limb versus forelimb. So the forelimb PSL desmopathies have a higher return of rate to work 1 year after diagnosis, whereas the hind limbs is kind of, they're a little bit more challenging to treat and have a little bit of a lower return to work. This study, though, that I read on Western performance horses, where they treated hind limb suspensories and forelimb with either Shockwave or PRP treatment, the Shockwave meant that they were 3.8 times more likely to return to work after 1 year, which is quite significant. And then just one of the Piezowave studies that was carried out in dogs on the ultrasound appearance of the supraspinatus and biceps tendon when they were treated with Shockwave. The cross-sectional diameter was much improved, but what kind of interested me more was that the lameness decreased enough to be statistically significant, which is kind of more of an interest to us as equine vets, because the ultrasound images can be whatever they are, but whether the horse is sound or lame is more important to us. And then just another study on the effects of Shockwave on bone healing. Now this study was in dogs, but I think it's still relevant that it improved bone healing. And this was kind of in TPLO patients in canines. And then just kind of my takeaways from this case is that proximal suspensory injuries, they really do require early and prompt diagnosis to kind of be aggressive in our treatment. And the Shockwave really is a core part of the treatment for this condition. And I think also as vets, we're quick to be like, okay, well, it's just the 3 sessions. Maybe if the horse doesn't have that option for surgery, or it's a very low grade lameness, I think it's something that we can continue to use to maintain these horses. So overall, I just think the Piezowave for me, it definitely enhances the treatment experience and provides kind of a more controlled and horse-friendly system for us to use. I can't really tell you the amount of times that I've been at barns, especially in Wellington, and they're all like, is that a Shockwave? And I'm like, yeah, yeah, it is. Like, it doesn't have to be this kind of, adversive system for us to use. And it's such a common thing for us to use in practice. So it's really great that we get to have this system in our practice. So I just want to say a quick thank you to Cindy for asking me to do this, and of course to our practice, and to Brendan for allowing us to have these really cool machines at our fingertips. So
That was awesome. Thank you very much. And does anybody have any immediate questions? We all know Cindy always has questions, but anybody else? You're welcome to type them in the chat too, if that's easier for you, but questions, ideas, thoughts? Here's my chat. Let's see. There was a significant OA change in the distal intertarsal, the DIT. Do you think degenerative enzymes from the joint have an adverse effect in the proximal suspensory? And if true, do you feel that the corticosteroids in the lower hock joints may have an adverse effect on the collagen of the fibers of the suspensory?
So luckily with this horse, we actually had previous x-rays. So the hock changes has like they have been consistent, like they haven't changed in the last couple of years. The only difference that we found was the changes on the lateral splint that were there. Um, and for me, that's more to do with the like proximal suspensory. Um, and yeah, I suppose we were just kind of thinking by treating the hawk, we might be kind of helping the suspensory too as well. But I don't know, I've spent a lot of time with a lot of the vets in our practice, and they're all like, oh yeah, no, we'll inject the hawk, and maybe some of that corticosteroid will kind of help with that inflammation in the proximal suspensory. Like a lot of people will actually do an infiltration in the proximal suspensory with a steroid to kind of help with that inflammation.
Yeah, and I mean, in these older horses, the longevity and the long-term steroid degradation isn't a huge concern because you're not doing it every single month, correct? Is that,
Yeah. Yeah.
you know,
And a lot of people like we do use PRP a lot as well. Um, so it's similar to how you would almost block the area.
um, when do you decide if surgery is indicated?
So it's a very good question because it was talked about in this case. And um, I think if the response to treatment of the 3 sessions of Shockwave doesn't resolve that issue, I think it's fair enough to have that conversation with the owner. I think a big thing is the owner perception and um what their hopes are for the horse. Do they want the horse to continue in their athletic profession, or are they okay with retiring the horse, etc.? I think a lot of it has to do with that. And I think there is quite a good response to the surgical treatment for it. Our surgeons would definitely be pro performing that surgery.
And did this horse go back to, he's went back to being sound? Is he going to go back to work in a jumping capacity or is he going to be a pet?
Yeah, that's what the hope is. So it's only a lower level jumper job, if I suppose if it was more of like a Grand Prix level show jumper, it would be a different conversation. It depends on the grade of lameness, I suppose, as well, and how they cope with coming back into work.
To us amateurs, those lower level jumpers are Grand Prix horses. They're our heart and soul. So, and
Well, yeah,
we get very attached to the ones that we trust,
yeah.
Um, but I guess one of my questions is stepping way back, and we always in the horse business, it's hind proximal suspensories that are so annoying and bugging and consistent with the desmitis. Why do we think the hind ones are so hard to heal and return to work in comparison to the front? Only because, yes, the engine is behind, but all the body weight's on the front. Do you have any idea on that? Is it a biomechanical thing or?
I would assume so, and it's probably the structures. Like it's completely different in the hinds versus the forelimbs. I feel like in the hind limbs where the suspensory is located, like it's such a tight space, and any expansion in that area, like there's very little room. Like the fascia is so tight. Um, that there's little room to compensate for that swelling. Whereas I feel like in the forelimb, there, especially in the proximal suspensory, there is that little bit more leeway. Like I have ultrasounded proximal suspensories on forelimbs that are that were enlarged but not clinically significant. The horse wasn't lame.
Believe it or not, I had somebody with a pulse vet recently who said they're getting better results on their hind proximal suspensories with laser. And I was like, I think you're just not targeting well with your pulse vet. But I said, try to hold it still, more still, because with our Piezowave, we can hold it still instead of having to move it dramatically with pain. So we'll see how she does. She's going to compare the Piezowave to the RLT vet. So
What I do as well when I'm using it is if the horse rests the hind limb and puts it non-weight bearing, in my mind, I feel like you're able to get deeper.
yeah, no, I
Um,
agree. Yeah, it's great if they,
so
yeah.
yeah, I'll let them kind of move between the two, um, to try and get different angles at it, I suppose.
Yeah, it's hard to get to. I mean, it's from the hind end because, again, you can only get it from the medial side, and it can be hard to get to. I agree. The fact that you can see any change in an ultrasound in a proximal suspensory is amazing because, gosh, I was those days you couldn't ultrasound them at all. It was part of my span of riding hind limb lameness. It was, and then we couldn't even MRI them, but now we can do everything. So we're gaining. We're gaining diagnostics, which help us heal better.
So, Cindy, thank you very much.
You're welcome.
So my comments on this stuff is that I've had Shockwave units in America for going back literally 25, 26 years. I had the very first dollar class that came in from Switzerland. And
Yep.
I used to have Dr. Steele, God bless him, used to send horses all the way from Florida to New Jersey for me to shockwave them. And then I got the very first precursor to the what is now the Pulse Vet. It was called something else then. And it was on a massive big table and trailer that you had to move around the clinic, so I couldn't bring it out to clients. That was great because they all had to come to me. And then they started making them smaller, which I didn't really like because now I had competition. So I've been doing it for a long time, and the Piezowave, I must say, that is on your sort of persistence, shall I put it, is probably, not probably, is the best shockwave unit I've ever had to use. Julie mentioned a lot of the salient points. Horses like it. They don't kick at you. They don't hurt you. You don't have to sedate them. And I feel that I'm getting just exactly the same results as it was with any of the pulse vets. And it's more convenient and a very easy on and off attachment. And no, I love the system. I would never go back to any of the others. And as our older systems become antiquated, we'll be buying more Pizos. But, you know, to Julie's point about it can be intimidating. It wasn't to me when I was a younger vet. Now it's a little bit different when I have a replacement hip and shit and I can't move nearly as fast as you. But it's pretty intimidating to get down behind a horse's hind leg and start zapping them with Shockwave. And I have concerns for the safety of our staff and everything else, but I have a lot less concerns about people's shockwaving hind legs with the Pizo than I have with any other system. And getting the same or better results. So,
you know, safety is important for sure for all of us.
Absolutely. Yeah, absolutely.
I remember you shockwaving Jason's stifle and it terrified Cindy. So there you go.
Yeah, and I mean, I got kicked shockwaving horses with the old systems, and I'm pretty savvy around horses. But I remember I had a quarter horse shipped into me years ago for the precursor to the Equitron, it was called. That's right. And I literally had to anesthetize the horse to do him. He was that violently opposed to it. And I mean, now you have to anesthetize them, you have to recover them, how much can you charge for that? You know, so. Your system is it's light years ahead of the other systems that I've used.
Well,
and I love the results with it. And I've never had a client yet say, "Oh God, I got much better results with the Pulsewave or the Equitron or this, that, the other thing." No, I've never had anybody say that the results are different or worse or not.
That's good to hear. I don't think they would tell you that anyways, would they, Dr. Furlong?
I'm sorry?
They would never say it wasn't as good as the rest.
Yeah,
would
yeah, they would. Yeah, they would. Yeah. And
Oh
I
no,
wanted to
they
say
would.
that, I had we were doing a horse yesterday for like one of the, he's probably number 2 or 3 in the world in show jumping, and he said, "Is that Shockwave?" I said, "Yeah." We said, "You can hardly hear anything." I said, "No, it's can't." He said, "Well, the horses don't react." It is so different than what we've had up till now. So, yeah, Julie, excellent job.
Well,
I think
thanks.
I taught you a couple of things, but making sure you don't lock suspensory horses up in stalls and you still make them work, and you have to have a rehabilitation program, and there's no magic to it. One Shockwave doesn't just fix them; you have to do other things as well. So,
Yep,
Yeah.
it's a process. It's a process.
absolutely.
And what are your thoughts on surgery, Dr. Furlong? Because there is a question about it.
So I think that so here's my thought on it. So hind legs only. If the ultrasound looks like the proximal suspensory is fairly grossly enlarged, and it's an older horse, and there's no drop of the fetlock, and the hock is not too straight, I don't have any problem recommending surgery on them. Take the pain away.
Yeah.
Yeah. But if they're dropping on the fetlock and the hock is really straight, it's a no-go. It shouldn't be done.
Mm-hmm.
Case by case. Can't
Yeah.
be.
Case by case.
Yeah, definitely.
Yeah. Yeah.
For sure. One thing that I was just going to say, Cindy, that I have noticed since using it is because we're not sedating the horses, we can see their response to when we're shockwaving them. So a lot of the time I'll see them doing like the licking and chewing.
Yep.
Like similar to like somebody massaging them or acupuncturing them, or like chiro release or whatever. They do the
They let you know when they feel it, and
She's more observant and younger than me, so she sees the licking and chewing. I couldn't be bothered me bollocks waiting for it. I just wanted to get the job done and get on with it. But no, she's right. I mean,
like they're enjoying
They
it.
like it. They tolerate it incredibly well.
yeah, it is, and you don't have to worry about throwing them in a stall sedated with hay and colic and blah. All that stuff.
If anything, sometimes if they're really bad, instead of treating them like injecting a joint, we'll just shockwave them instead.
You don't get kicked when the needle goes in.
Yeah. Yeah.
So I appreciate your help, Dr. Edmondson, because a lot of equine vets they won't make the time, and I know it's hard and you're busy. So thank you. I'm gonna bother you for some of the actual dates and notes, so if we can write it up as a full case study, and have it in writing. And
I did nothing but listen. I made Judy go.
and I thank you guys for all your support and your time, and I hope everybody it's almost Friday, has a great Friday, and thanks. I appreciate it. Thanks for coming. Thanks for listening. Any random last minute questions before we let Dr. Edmondson go? All good? Awesome. Thanks for your time. We really appreciate it.
Thank you. And Julie, thank you for putting this all together.
Thank you.
Thanks, guys.
Good night, everybody.